So, welcome everybody. Thanks for joining us for another episode of the group chat. We're happy to have you here with us. During the chat, please feel free to submit questions using the Q&A button on your screen. They'll go to me, and then the speaker will answer them at the end of the talk. This presentation is being recorded. However, no attendees will be identified. All images used in this presentation are the property of their respective owners. And as a reminder, the information shared during this presentation is not medical advice, but we will be providing additional resources at the end of the talk. So with us today, we have Dr. Sarah Crafton. Dr. Crafton is a gynecologic oncologist with AHN, and she specializes in robotic-assisted surgery and complex pelvic surgery for both benign and malignant conditions. She's currently the site principal investigator of gyne clinical trials at West Penn Hospital. We are very excited to have here with us today to discuss gyne cancers. And so with that, I'll pass it over to her.
Thank you so much for your kind introduction. The topic of GYN cancers, or an introduction to, is far beyond the scope of this short time together, but I'm hoping to give you a bird's eye view of everything we do all day long, and most importantly, symptoms to watch out for, reasons to call your doctor, and then, as Bree said, the resources of where to find care. So from an objectives, I'd like to review what we are, who we are, what we do, types of cancer we see, importantly, the symptoms, screening opportunities, and then some resources specific to our cancers. Briefly, quick anatomy lesson, but these are the GYN and reproductive tract cancers for which we take care of patients. The most common one that we'll have some dedicated time to discuss is uterine cancer. Uterine cancer is broken down to two other types of cancer called endometrial, or a second type called sarcomas, which represent the muscle malignancies. Sarcomas are very rare, but endometrial cancer is very common, and both of these would come under the umbrella of uterine cancers. Next is ovarian cancer. This is obviously a cancer people know a lot about and they hear a lot about because unfortunately it has historically been tied to a poor prognosis. Outside of ovarian cancer itself, there are two other types of cancer called fallopian tube cancer or primary peritoneal, and we think all of these are related. So one of the topics we talk about, or I talk about with patients, is if someone is being referred to as having an ovarian cancer, there's a chance it's also one of these other two that are all grouped together as one entity. In terms of the guidelines for evaluation and treatment, these are all grouped together. The third type of cancer that we see and treat is cervical cancer. So as you see on the picture here, the cervix is the bottom part of our uterus. The cervix is technically part of the uterus, but cancer that arises in the cervix usually arises from different reasons from the uterine. And this is what we use pap smears to screen. I talk a little bit more about that. And often involves talking about hysterectomies, which involves the uterus as well. So I personally find that it is confusing for patients at times, understanding the uterus and the cervix are part of the same organ, but just different portions. Finally, the last two are fortunately rare. We see a fair amount of vulva cancer. So in the big picture of the country, this is one of the most rare or least common GYN cancers diagnosed, followed by vaginal. The vulva is all the external genitalia or skin, and the vagina, of course, is the space, is the tube between the vulva and the cervix. These cancers are rare, but we see regionally a fair amount here and have a fair number of referrals to AHN for this. I particularly find that when I have patients with vulva cancer, they often say to me, I've never heard of this. I had no idea this could happen. I wish someone talked about it. So I'm specifically including it here to bring it out there to talk about that this is real and possible. And then finally, I included here, but this is certainly the most rare one. There is a phenomenon that can happen during pregnancies where the placenta or tissue around the placenta can actually make a transformation from benign to cancer cells. This is in general called gestational trophoblastic disease or gestational trophoblastic neoplasia. No quizzes here. You don't have to remember that really long word, but it's just a plug to say this is something that can happen. And if it were to happen, it is often referred to us as GYN cancer specialists. So this is a really long description of what we do, but I think it's the foundation of talking about the type of cancers we see and treat. So as GYN oncologists, we are physicians who have a unique course of how we became cancer doctors. All of us first did an OBGYN residency and then chose to subspecialize in the aforementioned cancers I just reviewed. And that subspecialty involved fellowship training. For most of us, that means somewhere between 3 and 4 additional years. A lot of that time is dedicated to the surgery about cancer removal, but we are the only type of cancer doctor that performs both the surgery as well as the chemo, also known as like the medical treatment for the cancers we see and treat. And so because of that, we have an elongated fellowship, and at the end of training, have the opportunity to offer the entire breadth and depth of cancer care to our patients. We feel that this is really impactful. We are empowered to be able to give this sort of care to our patients. And if you ask most GYN oncologists, the whole reason they chose this route is so that they could have that sort of personal longitudinal relationship by doing both the surgery and chemo for their patients. As listed here, radiation. So radiation, as I'll talk about in future slides, is one of the quote tools we have to treat cancer. We are not radiation doctors. There are certain radiation components that we're very engaged with planning with our rad onc colleagues, but we ourselves do not provide that. That is another common question we get about the type of medicine we perform. So we view ourselves as kind of the team captain for patients who have the cancers that I listed on that first slide. We often, at least here at AHN, perform the chemo and surgery as our specialty is designed. But importantly, we also collaborate with lots of other doctors at different hospitals, both in the system and outside the system, so that our patients could get a combination of perhaps surgery here with us or chemotherapy closer to home with their local providers. I think, though, that understanding the type of practice we do and the type of medicine we perform is paramount to understanding how we can help patients. So when we're talking about symptoms related to GYN cancers, this is where each of those cancers I listed are truly very different. We could spend an entire hour dedicated to each individual one and only scratch the surface. And so for purpose of the time today, I wanted to condense it to list the biggest high priorities and the things that I hear from patients that they wish they knew. So first and foremost, bar none, bleeding after menopause. So most of our cancers occur in women who are after the menopausal age or menopausal transition. And one of the most common symptoms that occur is bleeding. And so this is my public service announcement plug. If you are not established with a gynecologist or a primary care provider, and if you were to have any bleeding after menopause, that is a reason to call to get care. This always needs evaluated. And while the bleeding may represent completely benign things going on, the only way to know is with evaluation. Extending from the bleeding is also vaginal discharge. So I often hear women say, I never had heavy bleeding. I never had a period come back, but I might have had pink discharge once or twice when I wiped. And so I'd like to link these first two symptoms together. Any bit of bleeding or discharge, even if it's one time, even if it's just on tissue when you wipe, even if it is one speck, it needs to be evaluated. And so one thing you can do is reach out, of course, to your primary care provider or gynecologist, or here at AHN, we also have the opportunity for some of these same day and add-on visits, but this is a high priority symptom to seek care for. For those women who are not menopausal yet, any change in bleeding that involves more consistent or heavier bleeding also needs to be evaluated. I mentioned that most of our cancers are diagnosed after menopause, but unfortunately, and I have a slide about this, increasingly, uterine cancer is being diagnosed in a younger population before menopause and can be represented only by a change in bleeding. So the same rules apply. If this is going on, keep good records for yourself about your timing of your periods, your pattern of your periods, and any deviation from that pattern should be evaluated by a gynecologist. Listed here as well are several non-specific symptoms. So unfortunately, most of our cancers don't come with a kind of specific red flag symptom. Each of these things are non-specific and can be caused by non-cancerous reasons, but they are symptoms for which you should see a provider to figure out if what you're experiencing is normal or abnormal. Listed here includes pelvic pain. That could be acute, that could be chronic. any unexplained weight loss, any change in bowel or bladder habits, and that could mean of all ways, shapes, and forms, more frequent, less frequent, more difficult, coming with blood, no blood, any change from your baseline habits should be discussed with your provider. If you are in the habit of doing your own self-exams, specifically vulva exams, just how some patients do their own breast exams, when you are washing yourself or happen to notice any changes on the external genitals, it is important to alert your provider. And then finally, any vulva itching, burning, or pain, especially that is not short episodes or might be long lasting, that all needs evaluated. The most important part of our cancers is advocating for screening and prevention before you ever have to see a doctor like us. So the most important thing we can advocate for, and this could be provided by both OBGYNs or certain primary care providers who have a interest or affinity for women's health and GYN care, is an annual exam. And I think there's a lot of controversy out there about whether that annual exam must include a PAP. I think there's an idea that a PAP is an annual thing. That's a different thing I'll talk about in a second. But at least from my perspective, I advocate for a patient to have an annual pelvic exam and an annual appointment with a provider to review their GYN symptoms, specifically the ones I just mentioned. That exam should include both an external portion and an internal portion using a speculum. And then comes the idea of PAP testing. So historically, PAPs were, a brush that would swab the cervix once a year to collect cells to check for precancer or cancer of the cervix. And I think what happened is historically that PAP was linked to the annual exam. And the interesting thing that's happened over time is that as PAPs have evolved to be more specific and use other forms of testing, including HPV testing, it has become less necessary to do a PAP every single year. And along the way, some people have felt that it is not necessary to get an annual exam per se, but I'm here to tell you that I think would really advocate for patients to still pursue that annual exam and review of symptoms with a gynecology provider. The final plug I want to give about general screening and prevention opportunities for GYN cancers includes family history. Having a lot of good, thorough conversations with your family members about their medical history is paramount. Compared to 10, 20, and 30 years ago, we have a lot more information about the genetic predisposition that some patients have for cancers. So if there is a change in the genes that is present in a family tree and multiple family members have cancers, we could test patients in advance to see if they have that same gene malfunction. And if that's the case, we could talk about either surgery or screening to help prevent the onset of later cancer. Compared to 10 and 20 years ago, again, this probably gives us the most opportunity preventing things, especially like ovarian cancer in advance. And the better patients have of their family records and communication with their families about that history is really helpful. For things we do, at least once a cancer is identified, these are some basic tools for treatment, and this is reflective of most cancer practices. So if a cancer were to be diagnosed, the three general tools for treatment involve surgery, chemotherapy, and radiation. Those are three really generic topics. Specific to GYN cancers, more often than not, when patients need a hysterectomy, we use the laparoscopic or the robotic approach, which is small incisions, faster healing. That's really beneficial for the patient in recovery. Sometimes we do still have to use a large open incision, especially for a more advanced cancer, and this is more often when we're talking about ovary cancer. Sometimes patients need more than one of these tools used in their cancer journey. And so if they do need chemotherapy, I want to say that the list of chemotherapies approved by the FDA is hundreds and hundreds of hundreds. So if you were to find yourself in a position of needing to talk about chemo for yourself, while patients' family and friends' experience with their respective cancer is important, don't get me wrong, it is so important to understand which cancer treatment was used. And if you can extrapolate your friend or family's experience to yours, I find that a lot that patients come in and say, my brother had chemo for lymphoma and did very poorly. And I think it's important to say that each chemotherapy is different. Each cancer type is different. We have lots of different therapies available, and it really comes down to a conversation with you and your provider to understand what to expect. And then finally, our third tool is radiation. Again, we're not the ones directly providing that, but I'll tell you, we work in very close company with our rad-oncs to help provide this as a tool for our patients. Specific to endometrial and uterine cancer, so I wanted to spend a few extra minutes on those that are notable because I think we either have opportunity to prevent or improve education about it. And so uterine cancer, again, comes in two types. The lining of the uterus that you shed once a month during your periods, that's the endometrium. The most common cancer, uterine cancer, is endometrial. This is increasing in frequency. So disappointingly, even though there are lots of cancers, general cancers head to toe, that we are getting better at finding and preventing, and the trends are going down, this is the opposite. It is one of the few cancers that, as the federal kind of data tracks, is increasing in frequency. And we think that is partially due to the obesity epidemic. So all of the fat cells in our body actually create estrogen. And just by virtue of math, if there are more of these adipose or fat cells around, patients have more estrogen floating in their system. And we think that is what's stimulating the lining of the uterus to grow and eventually change into precancer and cancer. Because this is increasing in frequency, we are talking about it a whole lot more. When you get on the internet and you read about endometrial cancer, you will still find that, fortunately, even though it's increasing in frequency, the majority are still early stage, stage 1, limited to the uterus. That's represented in the far left uterine picture there. And most of these patients have surgery or some local radiation only. Disappointingly, though, as the frequency is increasing, unfortunately, so is the percentage of patients who are advanced, or also known as stage 3 and stage 4. Briefly, to talk about some staging, the word stage is non-specific. We use it in all type of cancers. Stage is a way for us to describe to each other where cancer has spread or where it's living. And in the right two pictures you will see for uterine cancer, stage 3 means that it is outside the uterus, the blue lines. It either spread to the ovary, the vagina, or the lymph nodes. And then stage 4 means it has traveled outside of the uterus to even farther away places, lungs, liver, other places like that. So while the frequency is increasing, unfortunately, so is the advanced stage and the percentage of patients who come back. So this is a really important one to be aware of. Any change in bleeding symptoms, again, frequency, heaviness before menopause, any bleeding after menopause, please seek evaluation. As I mentioned here, most patients who have endometrial cancer have a hysterectomy. And I wanted to just put a slide in here about this idea of robotic surgery. I get a lot of questions about the idea of robotic surgery, meaning a robot is doing it. That is not necessarily true. Here is a depiction of what it looks like. So on the right-hand side of this picture, that is the patient. The green dots, those are called ports. That's what we use our instruments in. And the robot itself is attached to the ports. But importantly, the robot makes no movement, has no control, has no independent thought or provision of care without the control of a surgeon. And so the surgeon is depicted in the picture sitting at this area called a console. And this is where, when we put our head in that viewer, have a 3D view of the anatomy, and we can control all the components of the surgery going on. So it's the opportunity for patients to have really meticulous surgery and faster recovery times and small incisions without the large up and down incision and extended hospital course. At the time of most of these surgeries, we are also removing lymph nodes. Lymph nodes, again, based on that staging system, are places where cancer can spread. We always sample these lymph nodes. I should say we most always sample these lymph nodes to make sure cancer has not spread. Outlined here, shorter hospital stay, less complications specific to transfusion and infection versus the up and down open surgery approach. Ovarian cancer gets a lot of press. It is not our most common cancer we see and treat, fortunately. However, it is one that has the poorest prognosis. And for that reason, of course, gets a lot of press. Interestingly, while the new diagnoses have been relatively stable over the last few years, the prevalence in the population is increasing because we're doing a better job treating it. So patients with ovary cancer are staying alive longer. So the number of patients in the population in our country is growing that has ovary cancer, but that's because they're living longer. Compared to endometrial cancer, unfortunately, the majority of these patients are diagnosed with stage 3 and stage 4. Pictures outlined here are kind of representing the same idea, that the blue is where cancer is living and where it has spread. So stage 3 means it's spread outside the ovary and into the belly cavity called the peritoneal cavity. Stage 4 means it has spread to fluid around the lungs, inside the lungs, the liver, etc. While most of these patients are advanced, even if you are diagnosed as stage 1 or 2, which is fortunate, it almost always still requires both the tool of surgery and chemo to treat. And then finally, genetic testing is paramount for ovarian cancer. About 10 to 20% of all ovary cancers are caused from a genetic mutation that a patient inherited from their parents' genes. And with recognition of that, it not only influences the awareness for other family members, but it also influences our treatment recommendations. So genetic testing is really important. I lumped cervical and vulva cancer together here. This is one of the most important reasons to have that annual exam. As I mentioned initially, PAPs may not be indicated every single year anymore. Know that the PAP recommendations are based on your individual risks, your history of testing. It's a very personalized recommendation now, as opposed to just blanket every year. But your annual visit and your annual exam, so that your doctor can physically evaluate and look to make sure all anatomy is normal, no growths, nor abnormalities. This is the most important part to identifying early cervix or vulva cancer if it's happening. I also recommend, as I mentioned before, self-exams. If you know your own body and your own anatomy, you are much more aware of finding those differences. And cervix cancer is preventable with a combination of vaccine and screening. As Bree mentioned in the introduction, I am the director of our clinical trial portfolio, and we think this is really, really important for women with GYN cancers. So in the big picture of cancer, all the cancers I mentioned here are considered rare compared to more common cancers like colon, lung, and breast. And because of that, it's really important that we pool our resources together so that we are coming up with innovative treatments to help make the trajectory of these diseases better for our patients. All the pictures I have listed here are from a group called the Foundation for Women's Cancer. This is a nonprofit organization that both provides patient education, but also provider education about these topics, as well as a respite for some clinical trial training for patients' education. And so this is obviously a topic near and dear to my heart, but briefly, there are a few different types of clinical trials. I know sometimes I think that phrase clinical trial elicits some anxiety, like it's experimental. A lot of thought and a lot of planning goes into these questions. And the only way that we can move cancer care forward is by asking these questions and finding the answers. So briefly here on the bottom explains these various phases. Clinical trials first get thought about in a lab, where there's lots of lab testing going on to ask what are the changes in these cancers that make them unique, what are the treatment options. If we find in the lab evidence that there might be something to use, a target, a drug, it is then developed into what's called a phase 1 trial. These are trials that are small in number. They only enroll a few patients, and the goal of that trial is to give medications and help figure out the safety and the appropriate dose. Sometimes these medications are given to patients with lots of different types of cancer. Once we do a phase 1 trial and we understand the dose, the safety, and even sometimes how well it works, the drug can advance on to what's called phase 2 testing. Phase 2 testing is we enroll much more patients, and the whole point is to define how well does this drug work to treat this cancer. So what we are saying is usually it's given to a big group of patients, and we're defining how well it shrinks cancer or makes it go away altogether, as well as how well is it tolerated. If drugs pass through the milestones so far, it then moves on to what's called a phase 3 trial, and this is really, really important. Phase 3 trials are when there's something called randomization, where people hear about they have an equal chance of getting group 1 or group 2. And what we are comparing as investigators is to say half the group in the trial gets the standard of care treatments, and the other half gets the experimental or the new drug of interest. And phase 3 trials are the only way that we can advance cancer care forward. From the Foundation of Women's Cancer website, this is a list of some of the trials that for GYN cancer truly changed the standard of care. So these are all trials, ideas, or drugs that were developed early on, shown to be safe, shown to be effective, and then compared to the standard of care. And due to the results of these specific trials, the standard of care changed for the better. This is how we advance cancer forward to make the outcomes better for present and future patients. This is where, Bree, are you going to go over some of this information? But this is the general resources Bree will go over next. Thank you for your time.
That was wonderful. Thank you so much. And if you guys have any questions for Dr. Crafton, please feel free to throw those in the Q&A now. But just in case people need to drop, just a reminder, we have one more group chat. I think it might actually be our last of this year. It'll be September 26th. We'll be discussing uterine fibroids if you'd like to scan that QR code to register. If you would like to book an appointment with AHN Gynonc, that is the phone number and the link to Find Care. And if you'd like to learn more about our services and programs at AHN, you can scan the QR code on the right. And then we'll just jump into our Q&A. So what might be somebody's next steps if a screening test comes back abnormal?
I think it depends on the screening test. And oftentimes patients have these milestones happen before they reach us. And so I would advocate for patients to ask their providers details about that screening test, because I think most testing results are complicated. Tests have inherent limitations. A screening test is not a diagnosis test. A screening test is alerting patients that there could be something wrong and that you need more investigation. But to what degree it is timely or kind of, I don't want to say important, but necessary, or what happens next, is really dependent on which screening we're talking about and what the result is. So asking your provider a lot of questions about those next steps to understand is right, and recognizing that a screening test is not a diagnosis. It is a warning to look more.
What are the long-term effects of fertility and sexual health for someone who has a gynae cancer diagnosis?
It is completely dependent on which cancer we're talking about. And breaking that down into separate fertility and sexual health implications. So if you need a surgery to remove your uterus, tubes, and ovaries, the chance of carrying your own pregnancy can't happen. But there are lots of opportunities for having these discussions before treatment is started to best understand, can I keep my uterus? Can I have my eggs harvested? Meet with the infertility providers and save my eggs. I would say that question is right to ask, but it is highly personalized based on age, patients, future goals for fertility, and what treatment is needed. Specific to sexual health, patients who need to undergo menopause, unfortunately, because of either radiation or surgery, that has its own set of implications for sexual health, as well as the physical changes that happen from surgery or radiation.
How can someone reduce their risk of developing gynecologic cancers, and do obesity, diet, and exercise impact risk?
We think that obesity, anything that can tackle the obesity epidemic, in theory, should decrease the risk of uterine cancer, but it does not mean it still can't happen. So from a global community population-based level, we think that decreased obesity means decreased uterine cancer. Whether that's true on an individual basis, there's a lot of factors that increase that risk of cancer beyond just obesity. But of course, I tell my patients, any amount of commitment to diet and exercise for healthy lifestyle, if you end up having a cancer diagnosis ever, your body is better prepared to withstand surgery, chemo, radiation when you are healthy and active. Those are always patients that do better no matter what faces your body to undergo.
Great point. How does early detection impact treatment options and outcomes?
It depends on the cancer. For cervix cancer, I can tell you that it makes all the difference. Diagnosis of early cervix cancer, or even better yet, catching it before it becomes cancer and is only pre-cancer, is curative for life. Cervix cancer, unfortunately, can be very challenging to treat. once it's advanced. And even worse, some of the side effects and symptoms from the treatment itself are debilitating. So if we have the opportunity to catch it early or before it happens, it is curative from a prognosis, and it saves a quality of life that we may impact negatively with the treatments we need. So early vulva cancer detection, it is much more tolerable and easier for a patient to have a small vulva surgery than undergo extensive radiation. So for almost all of these, we save quality of life and life years by detecting them early. But detection is dependent on which cancer we're talking about.
Mhm. What is the role of palliative care in improving the quality of life for women with advanced gynecologic cancers?
Oh, I love this topic. Palliative care should be implemented right from the get-go. I think that there's some preconceived notion sometimes that palliative care automatically means you won't get treatment or you are enrolling in hospice. There's a lot of preconceived notions about the idea of palliative care. Palliative care is the opportunity to address symptoms to improve quality of life, and we can do that in parallel with anti-cancer treatment or without anti-cancer treatment. I think it is the most holistic way to view a patient with cancer is to say, we also need to be making you feel good to the best of our ability. And that is certainly using palliative care early on.
And I think this will be our last question. Are there any exciting clinical trials or advancements in the research at West Penn Hospital specifically you could share with us?
I love this question. Okay, so I have a talk have given in a few different forums about this, but 5, 10 years ago, if you had stage 3 or 4 uterine cancer, everyone got the exact same treatment. And while that treatment cured 70 to 80% of patients, we still had 20 to 30% of patients that recurred. And unfortunately, for patients with endometrial cancer, once recurrence happens, it's often a fatal diagnosis. And so, but everyone got the same treatment because we didn't know any better. And so within the last few years, there have been a few clinical trials picking out certain types of cancer, and for not to belabor the points, but some certain cancer types that we identify on testing from your tumor. And when we found those cancers and we gave those patients with those cancers different treatment in addition to their standard, we added immunotherapy called checkpoint inhibitors. There's a whole class of them. We found that women were living longer without cancer ever coming back. So we were increasing, we think, our cure rate. We think. It's still a little early on to commit that truly patients are cured for life more often, but at least in the short amount of follow-up we have, we know that they are living longer without cancer. And so how this comes back to West Penn, 2 or 3 years ago at our big annual GYN cancer meeting, it was in San Diego, 3 of the trials that tested this idea of adding immunotherapy to chemo were presented all at once. And all 3 of them showed this, improvement in survival. And the presentation got a standing ovation. Everyone in the crowd was going crazy. It was awesome. Comes full circle back here because we had the opportunity to have all 3 of those trials open here, and we enrolled patients in all 3 of those trials. So I know we were particularly, kind of touched by this because you really felt like you were part of the bigger solution. Mm-hmm. Clinical trials are an immensely big undertaking. The phase 3 trials that change the standard enroll hundreds, if not thousands of patients. And so to feel like you're part of the solution and actively providing that access to patients on the ground here at West Penn was the coolest thing to be a part of. We're part of a lot of trials, but to see it culminate in a standing ovation with 3 good outcomes was really impactful.
Yeah, that's amazing. Well, thank you so much for being with us here today and sharing all your great expertise. And thank you, everyone who joined us. And we'll hope to see you on the next group chat. Have a good one, everyone.